Dr. Sumita AGARKAR, she's from Shankar Nethralaya, Chennai, and a master in pediatric ophthalmology, particularly pediatric cataract. It will be a pleasure to see her talk on management of congenital cataract in the 21st century.
Thank you for that generous introduction. I wish it was true. So I'm going to talk about pediatric cataract. So it's a rare but important cause of childhood blindness and can be responsible for 5 to 20% of the pediatric blindness worldwide. Of course, the incidence is much higher in economically poor countries, and definitely anywhere between 1.8 to 3.6 per 10,000 live births. So, which is a huge burden in terms of morbidity, economic loss, and social burden. So, these are the various etiological factors, and they are all self-explanatory. And you can see in a pediatric clinic a whole spectrum of children presenting with cataracts in different ways, starting with lenticonus with posterior capsular dehiscence to steroid-induced cataract here. In between, there are several with trauma, both penetrating and congenital cataracts, etc. So preoperative evaluation we should attempt to record visual acuity, because better starting visual acuity often leads to better prognosis. So every attempt should be made to record what is the preoperative visual acuity. Detailed anterior and posterior segment examination on slit lamp helps in very young children. You can use the indirect ophthalmoscope to give you some magnification and you can see. If possible, you should check intraocular pressure. Otherwise, it is possible to do all of this before starting surgery under anesthesia. Of course, digital biometry or lens power calculation if planning. Ultrasound B scan if there is no view of fundus. And of late, there have been several publications on using UBM to give more information on posterior capsule, zonular status, and vitreous state, and if there is any posterior capsular dehiscence in very young children, sometimes UBM is more useful. Again, AIOS2025 has been very useful in certain situations like measurement of the bag size. There is a recent publication from PGI Chandigarh about how they use the information of measuring the bag size to decide IOLs and decide whether to possible to put an IOL in a child who has slightly smaller anterior segment. So, and also it helps you in the interaction, it also shows you how the vitreous is interacting with posterior capsule. Sometimes it has helped in intraoperative decision making, and that's a very nice article by Dr. Sukhija and his colleagues. So management, again, if there are very small and very peripheral opacities, you can probably observe, give appropriate glasses, but anything more than that, probably they all need surgery. And importance of early surgery. So a cataract which looks like this with a peripheral opacity need not really do surgery, and this patient can be very well managed with glasses. So these are the surgical challenges. You have sometimes facility of anesthesia itself is a little dodgy. Sometimes I'm talking more in terms of our country here. Sometimes small eyes with coexisting morbidities, a very elastic capsule, need to deal with posterior capsule and vitreous at the time of surgery means you should have a really good vitrectomy machine, and reliable DBR and availability of the library of lenses, management of aphakia and follow-up. These are all not just surgical but post-surgical challenges also. So these are the steps of surgery in children, and I would think management of the anterior capsule is really the most key step, and there has been instrumentation available in terms of Zepto laser or vitrector sometimes, but still manual CCC probably has the safest edge, which is least likely to extend. Dyes and cohesive OVDs have really made anterior capsular management really easy. So here I'm just showing a small video where this capsule in 10 years back would have been very challenging, but because of the presence and easy availability of the dyes, you can really see that it has made all the difference to correctly size the capsule, correctly size the anterior axis, as well as the other video is of a fibrotic capsule where you may have to think on your feet, where you have to actually use MVR blade to make the initial entry, and then you can use scissors. If the capsule is not fibrotic, you can use a Utrata or a microcapsular forceps to make that rhexis. And as I said, both these situations, you can see the OVDs and dyes both make a whole lot of difference, and that has really changed the practice for us compared to surgeons who were operating earlier. Cortical aspiration, mostly they are soft cataracts and you can aspirate them. Maintaining anterior chamber depth prevents the AC collapse, but occasional child may have a very dense nucleus, and here probably you will have to, if you see a densely formed nucleus like this, this is a 8-month-old baby, but you can see it's almost like a soft adult nucleus, and I had to actually use a phaco probe because of its wider bore, and still I struggled with this because some of these you may be surprised by the density of the nucleus. So you have to be prepared and keep your phaco probe tuned and ready if you need to use it. Some difficult situations, traumas are always a difficult situation. So is the persistent foveal vasculature or PHPV, where you can have just a partially absorbed cataract with a dense vascular membrane and no dilatation, and sometimes despite using synecholysis, these patients may not dilate and they have often a tendency to bleed on table, so you may have to use cautery to a 23 gauge cautery to really. So despite stretching using hooks, I am not able to get a good dilatation to really and if you leave it with the membrane or really don't do a little half-hearted approach, then you're likely to develop again. The membrane will grow again and you will not serve the purpose of surgery. So I've done a little bit of a pupilloplasty using a vitrector, and that really dilates the pupil, and then it's only a matter of patiently cauterizing every blood vessel which is going across, and using scissors as well as cautery in conjunction to fashion some kind of a visual axis which is clear of the cataract. And as you can see, it's just a membrane. It's not really, there is not much of lens cortical matter there, but you need to have this cautery, and of course because she had a very stretched ciliary processes, I did not attempt to put an intraocular lens here. So posterior capsule management, again very important, because a beautifully done surgery can undo with PCO within a matter of few weeks or few months. So whether every child needs anterior vitrectomy, probably not. Children who are older than 6 or cooperative to allow you to check pressures in the OPD, probably you can leave anterior vitrectomy and just do PPC in them. Posterior optic capture also does away the need to do vitrectomy, and again there is enough evidence to show that it can help you to avoid vitrectomy, and you can just get away with PPC and have good clear visual axis months or years later after surgery. You can do a vitrectomy after IOL implantation also. Intraoperative integrated OCT has improved surgical techniques, and it has really been very useful if you have access to that kind of a microscope. It allows visualization in greater resolution and improves outcomes on the table decision making. So for people who don't have access to that microscope, you can still do a good PPC manually. And I will just tell you one thing: sometimes don't overinflate and use a retro illumination, and you can see the posterior capsule much better. And here, if I had access to integrated OCT, it would have shown that there is thick attachment between the lens capsule and the vitrectomy, and I might have put the lens first and then done the vitrectomy. But so these are some. So then comes the management of aphakia. You have contact lenses, you have and IOLs as well as spectacles. So availability of foldable acrylic IOL has been really a game changer for a lot of us, and because it allows implantation through a very small incision and a very good chamber maintenance during surgery. There has been a significant decrease in post-operative inflammatory response and probably is a standard of care above 1 year of age. However, in younger children, even with IATS studies, it has not conclusively proved that it has IOL is superior over the aphakia, but anatomical parameters like axial length and corneal diameter play a role in decision making, and I think if you have adequate corneal diameter of at least 10 and axial length of 80, and appropriate surgical skill and ability to do follow-up, then you should probably think of IOL in infants. But apart from that, you probably have to, other factors like I have mentioned here, they should form a part of your decision making. Now, IOL formula, in perfect IOL formula is still a work in progress, and what I do is we calculate lens power calculation using two formulas and find the middle ground. We have done some work on Barrett's formula for children, and it has the prediction error was pretty much same as how it was for other standard formulas which we have used. Lens designs, again, this lens in the back is lens in the back probably is something which looks future, where you can again do away with vitrectomy, and you can have a clear visual axis, and probably this is one way of avoiding the whole vitrectomy thing. EDOFs and multitrifocals in children, very little evidence or long-term data available. Myopic shift happens even in children older than 10, so you have to be, they are moving targets and with unreliable biometry, and probably you should avoid the lenses till more evidence becomes available. Toric lenses can be considered as an option. There are at least 2 or 3 publications from India on the toric lenses, and this is my experience with 22 eyes. Of course, my average age of children in our series was around 10, and we were able to significantly decrease their astigmatism as well as improve the visual acuity significantly. So in selected cases, you can consider toric IOLs in slightly older children. However, when in doubt, aphakia is, I always maintain aphakia, a good aphakia is always better than messy pseudophakia. So follow-up is lifelong and relentless in children. New problems can arise despite well-done surgery. Follow-up must include visual acuity, refraction, IOP measurements, and retinal evaluations. And glaucoma and retinal detachments are vision-threatening late complications which require vigilance. Thank you very much for your attention.
Thank you, Sumita.
And yes, this is on request of Dr. Deepa. Please, if you have not registered,
right.
This is a nice conference coming up in Brisbane.
They have actually removed the slides, so. So yes. So a trip to Australia, yeah, for the. Australia.